people's being served, and then the numbers of servers. And mathematically, just based on that information, you can already work out the probability, that's what this P is, of there being I people in the system. So at any given time, what's the probability I'm going to have 5 people in my system? So 5 people in the queue, and being served, and so on, adding all that up, what's the probability I've got I in the system? And of course, well, it makes sense to think that it depends on whether I've got less than C, okay? So I've got C servers, or if I've got more than my C servers, you'd expect the probability to be more or less in the system will depend on the number of servers that you've got, how quickly you're going to be dealt with. But of course, each of our different service centres can have varying levels of demand. They're going to have busy and quiet periods. You naturally expect that not only you might have busy and quiet periods, but certain things take longer than other things as well. What we can do then, again, is we can set up a structure using differential difference equations to actually work out then the probability of waiting in the system. So given that you turn up under this sort of conditions, given these arrival rates, this number of servers, you can actually work out the probability of someone actually waiting in the system. And then the general idea is this. If we know, for example, here we've got shifts of the week, so imagine the day is broken up into 21 shifts, for example, we may know different arrival rates across the week. So, for example, you wouldn't expect it to be constant for any healthcare facility. There is some variation in there. And corresponding then to that is we want to set some staffing requirements on top of that, which is the top line. So in this kind of picture, we want, of course, the number of staff to cope with the amount of arrival rate that we've got going on here. And there's nothing stopping that staffing requirement also to be dynamic in a sense that when we have a dip in the arrival rate, there's nothing stopping us having a dip in the staffing rate. So the whole idea what we want to do then is if we want to try and set this top line, if we want to try and say how many staff that we need a good prediction of what that bottom one is. Once we can predict what that bottom one is, we can carry on this graph on and on. We can then set the top one by just laying it on top using some methods that we'll discuss later. So here's our idea then. We take the historical data, all the historical information that we've got about these arrival rates. Then we use this technique I told you about, SSA, to forecast, to get some predicted arrival rates, what do we expect to see in the future. We can then use these O1 queuing theory techniques that I just showed you in a couple of slides ago. They can set our staffing requirements. Then once we've got that, of course, there's no reason to stay static. We can then just update our historical data. When tomorrow happens, we can add that data onto the data. That then becomes the historical data, and we can predict for the next day ahead, or the next week, the next month, and so on. So that's the kind of idea that we're going to go ahead with this. So I'm just going to quickly talk, don't worry about too much about the maths, I'll talk about each step of what this SSA is. What we saw with this picture is there's bound to be various components which make up my arrival rates. Okay? We may know, for example, that Mondays will be busier than Fridays. We may know, for example, that January may be busier than February. So we want to pull out from this the natural seasonality components inherent within it. So what we do, this SSA technique takes this series here and actually splits it up into a number of components. The first one is an overall trend, which might be just something that looks like that. The next one might be just a component which explains, well, every 5 units of shifts, I've got something happening. When I add up all these components together, I recover my original one. But what we do is we get rid of the components we don't want and keep the ones that make sense to us, the ones we can explain. The component which explains an overall trend, the component which explains an overall seasonality. And once we've got that, we can just carry on those components to actually get the forecast that we want. So, jumping out of the maths then, how do we actually do that? Well, you can actually do this technique for yourselves, okay? There's many software implementations of it. Some freely available. The truth is that most are actually freely available as well. You can also do SSA within Excel if you want to, if you download a particular add-in, so you can actually do these forecasts yourselves. If you're familiar with MATLAB, then I can email you, and it's also available if you just Google it. You can get a MATLAB file, which will do this SSA as well. And also, if you're familiar with statistical software such as R or SAS, this algorithm is also built into that as well. So you don't have to try and reinvent the wheel on that one. So I'll pass over to Vince now to talk about the actual case study.
Thanks, John. Right, to finish off, Paul mentioned in that long slide of the case, all the stuff that we have done in Wales, some work with their emergency department. That's the emergency department of UHW, the Emergency Hospital of Wales, very big teaching hospital in Wales. We've got a very good relationship with them, do a lot of work with them. So the data we used is over this year period here, but we've cut it into two, and you'll see why, because we're going to test it basically. And we have what we call the training set, so from the 1st of February, from the 1st of February 2009 up until the 1st of 2010. These statistics, they give the mean number of arrivals of patients, right? So on average, 4 people arrive every hour to the emergency department at this University Hospital of Wales. But remember, what we're looking at is actually the arrivals per shift, okay? So that's just an inclination, but obviously we know that Saturday evening, it's very, very busy. If you ever break your leg in Wales, do it Wednesday about 10 o'clock. It's the best time to do it. And then the other set, the other bit of data we have left over is a testing set. So we're going to have now a staffing methodologies that we're going to compare on that testing set. We assume a service rate of mu equals 2. Now, that means we assume that a doctor, a server, can take care of a patient every half hour. Okay? Now, in this sort of literature where you're trying to find staffing levels for emergency departments, it's actually quite hard to find the amount of time a doctor actually takes with a patient. And very often the mu equals 2 is used simply because you have so many things that happens to a patient through the pathway of an ED that you don't necessarily always know. Okay, you know they arrived at 10 and they left at 2, but you don't know what happened in between. So finding details like that, anyway, with this data set, was not possible, and that's something that is inherent in the data. And then finally, as Johnny's shown you, we compartmentalize our weeks into 8-hour shifts. Okay. So we have 2 methods. A method we're going to call the mean method. So we simply take 21 averages. We look at the data, and we know that we've got 21 shifts. So we look at the average number of arrivals through those shifts. Okay. And then we have this second approach, which is we use SSAs. We use this forecasting technique to go through the data and simply forecast how many people are going to arrive per each shift. And it's a slight fib. There's actually a third approach, which is simply to use the test data set and get how many members of staff we should have had based on the test data set. So in other words, we compare method 1 and 2 to 3. And 3 is basically our benchmark. So 3 is correct, 1 and 2 are going to be wrong. It's a question of how wrong. So this is the data set. And what you see here, to the left of this vertical line, is the historical data set. And here, the testing data set. What you've got up here is the actual data set. And then what you have in a slightly darker font is the forecasted series using SSA. Okay. So you can see there's a fair bit of more variability than just the 21 means. Now, some initial results. So this is using the mean method. Okay. So what we have here, this arrival rate with the means, are the 21 means. So this is 1 week, but we just repeat those means throughout. So that's basically all the information you get from that arrival rate. So we have the 21 means, and then matched onto that, we have the number of staff we need, okay? Which is basically, most of the time, 6, but for 3 shifts, 1, 2, 3, you'll go up to 7, okay? So based on the means, that's the roster that you would accept. And in the literature, that is what's used most of the time, this historical mean. Because the Curie theory techniques themselves take into the account the variability that Paul was talking about around that mean, but not necessarily variability of the input parameters. So this, I should have said before, this is the number of staff that you need to ensure that the probability of weighting is less than 5%. Okay? So that's kind of your performance measure. What levels of staffing do we need to ensure this performance? So this is the mean method. And if we compare it to the SSA method, these are your arrival rates that are predicted by SSA. And importantly here, straight away, we've got a lot more variability in our staffing requirements. So it's still between 6 and 7, but we're actually able to pinpoint a lot more accurately how many more times you need 7. Now, to actually evaluate this against the third method, so against the actual data set, we developed slight variations of known statistical measures. So the mean squared error is very, very common, and we've slightly modified it to call it the alpha mean squared error, or the weighted mean squared error, which simply allows us to penalize over and underestimation, because the mean squared error simply penalizes being wrong, but in a healthcare setting, perhaps being wrong but having too many isn't as bad as being wrong but having not enough. So that's what we're trying to see here. And similarly to that, we have a cost, because you could assume a certain cost with having too much staff if they're not being used, as well as a cost of having not enough staff. So these are the measures that we're going to compare our three against. And every time what we're doing is we're comparing our predicted, using either the mean method or the SSA, to the actual number of staff needed. Now for a few graphs. So what's worth keeping in account is low is better. Okay, so this is the weighted mean squared error, and we would like that to be low. And what we've done is taken an alpha of 0.5 and a k equals 1, and that is equivalent to saying that we are not penalizing over underestimation. So we're just interested in being wrong, not necessarily how wrong or how bad. And what you have then on the side is, in the solid line, you have the cost, and in the dotted line, you have the mean squared error. Now, ideally, if Johnny and I's work is correct, what we'd like is for the lighter lines, so the ones with SSA, to be below the darker lines, right? Because we want the mean squared error with the SSA approach to be lower. So what you see here, when we're not worried about over underestimation, when we don't have any penalization, that we basically get similar results. In fact, you could probably argue that the mean method is giving you slightly better results. This is for varying levels of the probability of weighting. So I don't want anyone to weight. I want the probability of people having to weight to be less than 5% or less than 95%. We see at the staffing levels we get. The SSA method possibly underperforms. But there'll be a very interesting insight at the end of why that happens. If we go up, and so now alpha is equal to 0.65, k is equal to 1.5, so we're making it a little bit worse to understaff, so it's important to have a bit more staff than you might need. We see the light lines start lowering, and if we now go up to 0.75 and an extra cost of 3, we see that even more. And finally, if we say, well, it's actually very, very bad to not have enough doctors. Sure, we don't want to have too many, but ideally, we want to make sure we have enough. Then we see that the SSA method gets a lot better than the mean method. Now, if we try different values of alpha, because obviously we just picked a few values of alpha and k, if we try different values of alpha, we get similar graphs. What we have here is a probability of weighting less than 0.05, and as alpha goes through, we see that the lighter line dips under. In other words, the SSA method gets better after a certain point. So that's the point at which over and underestimation makes no difference, and then to the right here we see that SSA performs better. Similarly, for a probability of weight less than 0.1, but the differences are much lower. Now, this is actually quite insightful. It's quite neat, really, because the staffing algorithm that we use, so that was the methodology that Johnny showed you at the beginning, basically maps from your demand rates to your staffing numbers, okay? But as your performance measure gets gets high, in other words, as that mapping between the demand rates and the staffing levels becomes almost bijective, in other words, becomes very, very thin, your step function gets very, very small, then SSA performs a lot better because it's this step function where the steps are getting much, much smaller. So that's quite neat. We get similar results for the cost, but I'll glance over those. To conclude, basically shown that there's these known queuing theoretical techniques that, as Paul showed you, take into account the variability for given input functions, and we've tried to extend that by using powerful statistical techniques. We've used SSA. It would be interesting to see how others performed, but due to the non-parametric nature of SSA, it's foreseeable that this could all be put into a nice package. And going back to that cycle that Johnny showed you guys with how you would update your historical data, that could all be automated fairly nicely. And if there are any questions, I'd love to answer. Oh, sorry. Yeah.
Okay, just to wrap up then. In summary, I think hopefully we've kind of demonstrated that, with some examples in the case study that we feel that OR can make a valuable contribution. And as Vince said, we are working with various hospitals in Wales and NHS Wales and Department of Health on a variety of projects. It's something fascinating. We have a whole range of modelling techniques at our disposal, and it's not just one model fits all. We use optimization, heuristics, assimilation, and so on. But they do tend to be stochastic. You've seen that health systems are volatile. You've seen a nice example of where it's important to take into account that. We're having to cope with limited resources and so forth. Models that we develop I said that the theoretical work's very nice, but also very applied work, and we aim to have our models used by policymakers so they make informed decisions. So collaboration is absolutely essential. And finally, certainly there's an increased need, I feel, a strong point, very strongly about this, and the way the funding going in the UK at least is in this direction, and it's important that we are working with people across it. So we are working not only within our own communities, but also with people like yourselves. We certainly work with health economists in Wales for cost-benefit analysis. I mean, you can probably get a sense from the kind of work we do that data is important to us. I mean, we can build models even without accurate data, like we can take parameters of the best case, but the modelling through an ED, for example, classic. Why are these time steps not captured in an informed way? Why is there not the informatics system in place to do this? Why is it just we know when they arrived, when they left, we don't know what happened in between? It's all paper-based. It's just old stuff, right? So we need to work, with guys like you, really, for all sorts of conditions. Just a kind of little plug. As Jim mentioned at the start, and Jim knows Cynthia. That there's a new journal about to be launched next year, Palgrave Macmillan, and I'm one of the editors, and there's the other people there. So Sally and myself are really operational researchers, management scientists, and Cindy then covering more, and Faye covering more the informatics and other areas. So the whole point of this journal is a really nice outlet for interdisciplinary work. So we feel there's certainly a strong room in the market for this. It's really to kind of showcase when you're looking at a whole health system and identify where we can work together as well, and so where OR is making an impact, where informatics is working, and hopefully be a forum where we can get that kind of discussions going. So do look at the website, or Google Health Systems and Palgrave Macmillan for that. And Jim's on the editorial board for that, right? Okay, so it just remains for me to say thank you for listening. I hope we've at least given you a little insight in the time to what we do at least. Okay, thank you.
Great job of keeping time, so I think most people probably expect that we can have a few minutes for questions.
I love this sort of modelling, it's really cool. I'm a clinician though, I'm not a mathematician, and I guess you have to work quite closely with the clinical people or the policy people or the politicians, but I'd imagine that a lot of the outputs of these models will depend on the input, in other words, what assumptions you make or what variables you put into the model, and so, I mean, I guess there's a little bit of maybe politics that goes on about what goes into the models to get what comes out. And the other thing I was thinking about was, do you test how well your models predict subsequently after you?
Yeah, sure. Very good questions. So yeah, of course, we'd be naive if we didn't think that the model's only as good as whatever kind of data feeds it, right? That's the first thing. I think that depends on who the client is, okay? So clearly, if there's a political motive, then we have to be aware of that, right? In terms of the decision I made, it was the right thing. You're going to show me now that I made the right call. But often a lot of models we do, well, not like that. They are like working for local hospitals who are about to go through a major reconfiguration process and so forth. Or we're looking at, is it cost beneficial for to screen for a disease and so forth. So, but I do think they are objective. I think that's the key thing, because a lot of the decision making at the moment is subjective, or it's not always a clear evidence base. So I think where we can add to that discussion, and again, we can't claim that we would answer everything, right? But where we can add to discussion is that we can bring an objective, a quantified evidence base to that. So they can play, and they do, they can play out various scenarios using these models, which is where the power, I think, of the technique comes. So they can actually say, what if this happened? And they can see where they might want to be. We don't necessarily tell them where they have to be, but they can see what the consequences would be through various decisions. So that might answer the first part. And the second part, yeah, it's important. Validation of models is hard because they're complex systems. So, you know, before you can even go forward with a kind of what if, you've really got to kind of validate against what currently happens. And so that's something we've got to do that well. And yeah, we need to go back. We sometimes do go back, and you actually see what happened. So and then compare. But perhaps we don't do that as well as we ought to. I'm not sure what other disciplines whether you guys go back and test and see how well that's performed, or whether you. But maybe we do need to do better, I think, at that. And also, it works both ways. We do need to collect the evidence also that the kind of decisions we're making actually are beneficial in the long run as well. And it can be quite hard because health systems are often in a state of flux, and things change and come and go. New government come and go. It's always short term. So it's quite hard sometimes to actually measure the benefits of a new system. It's not always immediate. So, but we do that. Yeah, we look back at. The outpatient clinic is a classic example, actually. Well, that was implemented about 6 years ago. We go back, and actually the clinic is running much more smoothly. And that was about no extra resources, that's just simply by changing the schedule. So it's not about throwing more money at it, it's actually, you know, it's being more clever with the system you have.
I guess I'm quite interested in this because I'm looking at medication safety sort of aspects, and I'm just interested in whether you guys have kind of had to do anything about safety interventions, because we seem to do a lot of interventions and we don't really know whether that will be beneficial or there are unintended consequences. And I think that one of the difficulties is that there's so many variables associated with that. Have you guys tried to model medications management systems and that sort of thing? And what happens if there are so many variables to put into this equation?
No, have you done any manual, John?
Yeah,
some stuff on that.
I'm involved as a statistician. I'm involved in a number of clinical trials where there is such an intervention in exactly the manner which you described. Yeah, of course, lots of variables is a problem, and in fact, it's the eternal problem of statistics. You know, there's always lots of variables and various interrelationships between them. Sometimes such relationships are intuitive, and sometimes such relationships are counter-intuitive. Yeah, I mean, the only thing I can really say to you is we're usually aware of that problem, but we do usually have the techniques to deal with the breadth of the variables available and the complicated relationships between them. There's ever such a move now in statistics is that the amount of data just available to us has exploded. I mean, particularly with all this genetic research, I mean, we just have huge numbers of data and huge number of variables as well. The only thing we do is try to control for each of those variables as we go through an analysis. So, for example, I'm currently involved in a clinical trial which is evaluating the use of exercise for patients diagnosed with Huntington's disease. And of course, the variables which may affect the benefits of exercise is going to be age, for example, fitness when you start the study. And so we try to control from those variables from the outset. And some of the time, you're quite right, there's hidden variables which come to the fore much later on, and then we just try and control from them with these models. But numbers of variables isn't too much of a problem. It's just trying to understand the sometimes counterintuitive nature of how they influence something else.
Just as we do the questions, Jerome Ng is a hospital pharmacist and PhD student with
Jeff Harrison and Elmiri. Yeah. Sorry.
Internal introductions, many of us. Tony?
Well, I don't know if this is a question you can answer really, but it's sort of following on from that question that some of these models are hugely data handling, and I would imagine hugely labour intensive as well. And sometimes you must have to go, particularly if you're talking about a health systems model. You've got to collect the data. It's not readily, but you can't just go to a database. So, in terms of how do you answer this question? Time that you would spend, how many people are involved, what sort of size projects are these?
I don't think there is one answer to be honest. I mean,
no, well that's what I said.
No, yeah, like, there's not a typical project. I mean, it depends. I mean, a lot of the stuff though depends. If it's like the hospital service plan and stuff, like with the local hospital in Cardiff, then a lot of that is routinely collected data. They have patient management systems which collect data. You can debate how good those systems are and so forth, and that's where perhaps informatics can play a bigger role. But that data is routinely collected. We are very lucky in Wales to populate, like it's been in New Zealand way, there was 3 million people, so you 4 million. So we're in the NHS is Welsh controlled by our devolved government, so we have access to data which is a Wales-based population data. So we're quite lucky to have locally that access. So it means like getting hold of data is perhaps more straightforward than it will be elsewhere. So it can be routinely collected. Sometimes it does require extra data collected.
I was thinking in terms really about movement through the system.
Yeah.
We have good data about use of the system,
yeah,
time and movement through. And
I think a lot of times we're working with people though on patient like if we get called in a project, often they're going through that mapping exercise. There's things like map of medicine as well, anyhow, which so there are lots of maps already out there. People like drawing pictures of maps, and you get the whole map of the care of diabetes patients or whatever, or the map of the flow of the patients through a system. Sometimes that isn't in place, like the outpatient one, for example, we had students go around following patients to map out pathways and to count, and that can be a back to basics kind of thing. Sometimes these things are already in place, and then, but going back to your question about what's good enough, I guess, I mean, well, if you think what currently happens is very little evidence base, and so if it can even be it can be quite a crude or high level model, like the system dynamics model. That could be one extreme where you just get insights into how things impact on each other, and that requires relatively little data. It could just have expert opinions. You could have experts around the room talking about your system, and you could plug in some data and just play out some scenarios. Or it could be, I want to ensure that I've got the best schedule for my consultants and theatres on a weekly roster, which is quite hard problems to solve actually in terms of the constraints you have. You've got beds after the theatre and the intensive care bed, and they're quite hard mathematical problems. And so they would require to be good solutions would require good data. And so we're in the hands to some extent about what data is available.
In the New Zealand context, you could scrape quite a lot out of the IBA PIMS, out of the patient management system, about what wards people were in and roughly what beds they were in, but like the service times you couldn't readily scrape. We're going to be closing now. A flippant and a serious question. The flippant is I had heard that because the NHS had required a certain maximum amount of waiting time in the emergency department, they had the people waiting in the ambulances so that they wouldn't go to the emergency department. Yeah. Is that in any way true?
Yeah. Did you hear our talk this morning? That's what we were talking about, because we've been working with the Welsh Ambulance Service. And so, so some gaming going on, right? So there's some interesting also models to work out about, that's what the game theory is quite interesting, because there's a 4-hour kind of max time in A&E, or the emergency department. So what's been happening, particularly bad in Wales, is that we've been looking at the ambulance time. So a patient is then stuck in an ambulance waiting to be transferred over to A&E. And because that ambulance is a valuable resource, right? Someone else, 999 call, emergency call, and that ambulance is stuck for 2-3 hours sometimes or more outside an emergency department. So it's a glorified trolley, quite expensive trolley. But it's crazy. And this was actually in the news, it made the news. The talk we gave this morning in David Ryan's group was about that, and it made the news, and it's outrageous. But there's a classic example again where people say it would be good to actually reduce the time, the turnaround time, The Welsh Ambulance Service really had no quantifiable evidence to say if it was reduced by this amount, what impact would that make on the whole system, the response times for the whole thing. So the model work we've been doing is able to quantify that. If you were to reduce this time to this amount, to the government guidelines of 20 minutes, then actually your response times would go up from, your targets would go up from 65 to 7. So it's quite useful. So that then opens a dialogue, I guess, between the government and the emergency departments about the gaming situation.